Where'd you go this time?
The Finance Committee will come to order, please.
I've spent a lot of time on merit credits.
I see how much
Hardest thing
attention
I
you
had-
get.
I know.
Ken, we took that Falcon Airway, they sold it to GM, they all got like $30 million. All I got was an offload. I don't get to play on the carpet plane. Told Debbie, well, we're back on American.
All right, we're going to get started. We're going to have, are there any citizens who have signed up to address the committee? All right, no citizens this morning. First item of business is the minutes. We're going to have, we'll entertain a motion for approval of the minutes from the March 24th meeting. We have a motion by Dr. Weber. Second by Mr. Powell. Any questions? All in favor, please say aye.
Aye.
Against, motion passes. Thank you. Ms. Clark will have a CFO report, please. Can you be heard? That's a question I might have for you, if you can be heard with the audio.
You want to try
Here,
it? Here,
try that.
Sharon, see if you can.
Well, look at that, a solution around everything.
Hey, y'all don't want to hear anything Trent and I have to say anyway.
That is true. Oh, you're off camera. Uh-huh.
Can they find me?
We can hear you.
Okay. Chivalry is not dead, thank you. So you guys don't have to look backwards at the podium. I thought I would give this a try today to see if we can make the setup work a little bit better. So
We encourage innovation.
if it doesn't work today, we will go back to the podium. But
I thought you was going to say we're going to go back to JPS.
I
All in
don't.
favor, say aye.
That was a motion.
Is that a motion, Mr. Chairman?
I don't believe that's my call. But we will see how this setup works. There are longer presentations in my future as we approach budget, and I wanted to see how this interaction would work with me sitting at the table versus at the podium. So we'll go from here. And we may have some other takers at the seat today. So we'll just see how the older interaction works better with me at the seat. So a few updates today that I wanted to go over. We do have the single audit that is the what is the OMB Circular A133 audit that has been posted on your portal. We will not be covering that in detail today. It is a required audit if your entity receives greater than $300,000 of federal funding through federal and state awards. Tarrant County Hospital District received approximately $2.7 million of federal awards and $1.2 million of state awards for a total of $3.9 million in fiscal year 15. The report states no instances of non-compliance or reportable conditions. It is posted in 2 places for your review. It is both under my CFO report for today's agenda, and it is also in the resource library under the audit section. So if you want to go out and review that report, it will be there. And if you have any questions, feel free to contact me. I'll be happy to answer any questions. But that is an annual audit. BKD does perform that audit as well for us. So.
Any questions for Sharon on that item?
Right now.
Not at the moment. Thank you.
I would mention it is an audit that has zero materiality. So any one item that they find out of compliance would be reported. So we are very proud of the no reportable conditions at this time. So The other update that I wanted to report to you was on managed care. There are no, as you may have noticed, there are no managed care contracts for approval for the month, this month. We do plan to bring those back to you next month. There are some that we are working on. We were unable to bring those to you today based on just the back and forth nature of those contracts, but we do hope to have some additional approvals on next month's agenda. So just a heads up, there are some in the works, and we continue to work on those diligently, but I wanted to let you know that. So those were the two items under my report.
Any other questions for Sharon on those, on her report? Okay, thank you. How about we go on to 5A, the financial report.
We did have another strong month for March. If you had a chance to review the financials that were sent out, again, admissions were very strong for the month of March compared to what we expected in our budget, as you can see by the graph. We were about 5% ahead of budget for admissions, as you can see by the blue line in March. We had 2,284 admissions, which was stronger than last month. We did have a few additional days in March than we did in February, but still a very strong month. Our case mix index was down slightly, and you can also see the average length of stay by month was also up quite a bit. And I wanted to explain to you exactly what is average length of stay, because it is a quirky calculation that we have as a hospital. Average length of stay is calculated by those patients that are discharged during that month. And it can be skewed by one or two patients or a group of patients that have an unusually long length of stay. So any given month, if you have a patient that has had, and we do have patients that have, in excess of 90 days length of stay. So if you look at this month, we did have more than usual an excess length of stay greater than 90 days. So it did blip up for the month of March. If you looked at our year-to-date, we are still slightly higher than our budget of 4.95 days. We're averaging just under 5.2. However, our case mix index, which is the acuity of our patients, is slightly up as well year-to-date. So it's just a 1 month calculation. We'll continue to watch that throughout the year.
Sharon, if I could ask, from a financial perspective, what's the relevancy of that metric?
The length of stay kind of drives your utilization of resources. So from a financial perspective, I would like to see our length of stay. There are quality indicators that as you have diagnosis, you have an expected length of stay that's associated with each diagnosis. And you would like to see that length of stay come in as close to that expectation as you can. Even if a patient is just here for an extra half day, it's taking up the bed, it's taking up potential medication, it's definitely taking up staffing resources. So we watch, as a management team, our average length of stay very closely. There are other things, socioeconomic, case management, that often you cannot discharge a patient necessarily exactly based on that expected and derived target that you're shooting for as well.
So the point is not to minimize your length of stay, it's to
Correct.
optimize it to the diagnosis and not
Exactly.
go over it more than those things that you assign to why it can go over.
You
But
said that much
financially,
more eloquently than I did.
I don't usually do that.
Yes.
But financially, does it cost the hospital more? Does it cost hospital? I mean, how's our reimbursement? I guess it depends on the payer, but
The reimbursement does not change based on our average length of stay. And it doesn't necessarily cost us anything if your average length of stay is higher. It's just an indicator. It could cost you more depending on how you staff and flex the staff. It's dependent on
a lot of
a million different indicators.
Right.
It depends on if there are people waiting to get into those beds, and so it's not a black and white indicator on necessarily how you are doing, but it is an indicator in which we evaluate each month very closely. It's an important indicator for our hospitalist group and how we are communicating with both our discharge planning, but it is an important indicator of within our operations.
Got it. Yes, sir.
The question, as it relates to, when we see it on our report, it's almost like an activity measure instead of a performance measure, because it's not shown relative to any particular standard. And if the standard is established based on case mix index and acuity, is there a way to correlate this to an actual performance measure relative to those case mix indicators and what we should be expecting length of stay to be per diagnosis?
Let me visit with some people on that, and I can study that a little bit more and bring it back to you.
Sure. You said this kind of, it sounded like the way we do this is kind of kludgy. Is this different from what other hospitals do?
No, the average length of stay is a very standard calculation across the healthcare industry.
Would it be fair to say that costs are driven by the people who are here a lot longer? Is that, or once they're here and they're checked in, are they cheaper?
I would say, and this is fairly standard, from a patient care perspective in general, a patient's resource utilization is higher during the first part of their stay. And then during the latter part of their stay, that is usually kind of, you're weaning them off of the drugs. You think about a surgical patient or infectious disease patient, when they're here, you're running a lot of tests, MRIs, CTs, right, and so the higher cost is at the front of their stay, and then as they get ready for discharge, you are more just prepping them to go home.
Right.
So, as the last few days of a 5 or 6 day stay are not when that patient is taking up the most of the resources. So even if a patient stays another 6 to 8 hours longer, it's not as if, they are, they're typically not on any high-cost drugs. They're not taking a lot of nursing time. It's more just about patient flow and the right thing to do and efficiencies. So,
Is there a metric that talks about perhaps the outliers that are here a long time?
yes, and there are, discharge management watches those outliers closely. Case management will watch those outliers closely. So there are teams of people that do nothing but watch those folks that are ready for discharge but still here.
Right.
So those people are highly managed.
But a few hours is not really an outlier, right? We're talking about
No,
days.
we're talking about days. And I think at the last board meeting, we talked about some of the folks that may be inpatient for months here at our facility. And although they are highly unusual, they are not unique to JPS or any healthcare facility.
Yeah, I'm always interested in, how we compare to other hospitals. Do we have lots and lots of these guys, or do we, how do we stack up just in comparison? And I'm not sure what the metric for that would be or how that'd be calculated, but just an interesting idea.
Yeah, every healthcare facility that I've ever been involved with has, those outliers exist. And, it's part of doing business when you have, 2,000 admissions a month.
Right.
Those things will occur in a facility. So,
Mr. Wynn?
So the daily census is about 500-600 a day? Is that right?
Say again, I
The
couldn't.
daily census?
Um,
You have 2,000 a month, somewhere around there?
I don't know what the average daily census is off the top of my head. I'm sorry.
If you have just a few cases that are 90 days, should we be looking at sometimes physicians have a tendency to keep the patient an extra day or two because they don't have a place to go to discharge.
We do. There are teams of professionals that are reviewing the patients that are inpatient, and discharge planners that are reviewing those patients every day.
Are they coordinating with the appointment scheduler to schedule them to see if they can find a place, clinic for them to go?
Absolutely, yes.
They are.
Yeah.
Yes, ma'am.
It's on the, when a patient, I guess I'm talking back to the payer, is there a certain amount that if you are in 5 days, you get the same amount that if you're in for 30 days? Is there,
Most of our payers will pay you based on a DRG or by an admission. Then they will reconsider based on other complications that may have occurred during your inpatient stay. But, you will typically get paid not based on the number of days that the patient is in here, but based on the diagnosis.
okay,
In general, those are just general
yeah,
terms.
okay, so the longer they're in, even though at the end the cost is less, you've already got the bulk of what you're gonna receive.
Correct,
That's the reason you're monitoring the length of stay so that you can,
correct.
Is a JPS connection using Medicare, DRG? Are we paying per day regardless of the length of stay?
Connection is usually based on now, from a connection standpoint, understand, connection has contracts with the professional providers. So we pay the physicians based on Medicare rate. We do not pay the facility under similar contracts, right? Because that would just be cutting a check to ourselves. So we do not have, we don't issue a rate to JPS facility. So there's not a contract with ourselves to pay.
So we don't pay.
We don't pay ourselves a rate. So that's not a,
We're just dealing with the cost side of it.
correct.
yeah.
So if y'all are ready to move on to outpatient volumes. Our emergency department was 12.5% over for the month compared to our budget. Urgent care was right on budget for the month, and up quite a bit from our volume from the prior month. Our total clinic visits exceeded budget this month by 1%, and you can see by the blue line in March, we were at the highest volumes in our outpatient clinics month to date for the entire year. So we were almost at 64,000 visits this month in our community health clinics. And some of our other outpatient, our observation days continue to be very high. They were about 11% over our forecasted budget. Our inpatient surgeries, even though that graph shows to be red, we were just 2 under budget, right at about 500. Our outpatient surgeries were 25% over budget. And once again, highest monthly volume year to date. Psych continues to be high. Our patient days in psych were 5% over budget. And our ED visits, again, were about 8% over.
But those partial hospitalization days, why are those 2 months?
Say what, Trent?
The partial hospitalization days, and we got 2 months where they're really kind of blowing the top off the budget, and I'm just curious if there's a.
The partial hospitalization days, I'll speak off the cuff, and if I'm not completely correct, I'll follow back up with you. That is a relatively new program that we have, and I believe that they are ramping up that program. So as it starts to get really established, I think they're kind of finding their pattern.
What is it?
Yeah, we've not seen this graph before.
Yeah, it's a new one, I'm not familiar with it.
The partial hospitalization is kind of a day program where it is more intensive than an hour or two of therapy. So it's an alternative to an inpatient program. So it's kind of a hybrid. So it might be more of a 6 to 7 hour day where you're in a day-long program, but it's not overnight. It is not an admission, it is an outpatient program, but it's not overnight.
Okay.
Is it like an observation day?
No, I don't believe it is an observation day. It is just a more intensive, it's a build you.
It's a structured program that takes place during the day. There's no overnight stay.
Right.
But it's very structured and observed by clinical professionals, but they're structured.
How does
Behavioral health perspective.
how does the district get paid for those folks? If it's not a DRG and
Contracts.
contracts, okay.
So it's supposed to be taking place, is somebody staying a whole day, or is it
Correct.
supposed to be, that's the goal, right?
And I believe that the patients are scheduled like Monday through Friday. It's a routine that the patients are in. It is not haphazard. It's more of a week-long therapy that you're scheduled to be in for an extended period as an alternative to a long-term admission.
Right.
It's kind of, my understanding is on behavioral health, is that if a patient is having a crisis, that would be where they would come instead of coming, it would help, they would be able to come there every day, have that group session and stuff. So it's mainly targeted for behavioral health only.
So the alternative is, again, it's the institutional, or the.
Right,
the
and
long-term
going up to
stay,
the
staying
ER
out.
crisis center. So that's my take on it, but.
Would it be fair to say that the vast majority of these are mental health patients? Is that right?
All of the.
Oh,
All of those
absolutely.
are. All
This
of
is a
those are.
psychiatric
All of
them.
slide,
Yeah.
yes.
Then yes, it
Yes.
is fair to say.
That sounds like a good program.
It
That's what I'm
is,
saying is,
Yes.
it is a good program.
Yes, all four of these graphs are for the psychiatric program, even though it's not stated in that
Word
one.
psych is not part
Yes.
of that, so it
Yes,
confused me.
sorry about that.
I'm easily confused.
It's not clear on that one graph. So on our FTEs, per adjusted patient day, both our calculations, our total paid and the with exclusions are both favorable to budget year to date. And our days cash on hand, as at 310 days for the month. I will remind you that January and February, we did get a little spike, once again, because of the receipt of the tax revenue that we did receive. And then our payer mix slide, this graph does not change dramatically in any one month.
I know I'm always expecting something different when I see that one, but it's always the same.
It will not change, but it's good to look at.
If we're committed.
And then our JPS connection enrollment, we are still on the uptick. We were able to enroll another 650 members for about a 1.5% increase. We have recovered from our slight decline in January from the ACA enrollment. So we are back at our pre-December levels. And then, as I mentioned at the beginning of my financial presentation, we did have a really strong month, once again, in March. I do want to point out that we had a year-to-date grant adjustment that has impacted a couple of line items within the financial statement. It was a revenue in and an expense out. So it impacted both the other operating revenue to the tune of about $3.2 million. We received grant revenue here, and it's also reflected in supply expense of about $3.2 million overage. And that, again, is a year-to-date adjustment, so about 6 months worth of revenue and expense was recorded this month for some patient drugs, mainly a new Hep C drug and some vaccines that we were able to bill to the grant, and we expect payment back from that. So that was a great thing that we were able to provide through our community health clinics. We were able to collect that information and get it off to the appropriate grant. Some other things that happened this month that we've already talked about through some of the volume slides that I've covered was the strong inpatient and outpatient that provided us with about $2 million of net patient revenue. So that was shown up on the top line. And then as you look down, again, as we've had in prior months, we've had some savings in our purchase services. A lot of that, again, is timing. Some of it may be permanent savings throughout the year, but I think as the year progresses, we'll see some catch-up of those purchase services. And along with the supply expense, again, about $3.2 million of that is the grants, but with the patient volume, supplies were over, and then our invasive lab, as we continue to grow that program. If you remember, it opened in September, so we underestimated the volumes and the expenses that we would incur in that program. So a lot of the supply cost overage is related to that new program that we opened up as well. So at the end of the day, the income from operations for the month is $5.6 million, or about $2.8 million ahead of our budget. So year to date, we are at $31.5 million. Is there any questions that I can answer for you for March?
Good. In the pre-ACA world, there was a mix of payers. How does it change? How does that look from the graph that doesn't change now? If you go back to the pie graph, income, or payer mix. If we were looking at this from 2 years ago, what would be different?
So, your question was before the ACA entered our healthcare world,
Right,
what would the pie look like?
right.
And I don't know what the payer mix at JPS look like, so I'm gonna just put on
Right,
my
you weren't
general healthcare hat. I would say the self-pay piece of pie looked a little bit larger. And this managed care, sorry, let me find my orientation here. This commercial pie was a little bit smaller.
So we've moved some of the people who are self-pay, now they're being paid
Some
for
of
by
these
a
self-pay folks have moved into the commercial.
And so when we look at the dip of enrollments that we had, we're filling back in, but we're filling back in with people who are paying using ACA.
Correct. Now, the complexity that JPS has is that we have this connection piece of the pie. Now, connection, by definition, you can't be eligible for connection if you are eligible for any other program.
Right.
So as ACA came on, if you remember, let's see, when ACA came on in January of 2015, all of these connection program patients had eligibility for connection. I mean, for ACA. So we had 23,000 patients that immediately either were or thought they were eligible for an ACA product.
Right.
So perhaps in 2015, this connection pie was much larger. Now, just because we had 44,000 enrollees does not mean that they all access JPS Hospital, correct? So that 44, it doesn't mean that that 20% was 40%. So just because we had 44,000 and it reduced to 22,000 doesn't mean that all of those people equally access the hospital. So I just want to point out that enrollees doesn't translate to percent of revenue.
Right, because a lot of these numbers.
So they may not have ever utilized the hospital.
I've been learning
So,
that a lot of
okay.
these numbers don't
They
reflect
never
that.
come in the door.
They may not have. So it might have been 25% connection. Right,
Right.
even though these charts may not correlate, they don't correlate one for one. So connection in that pie chart might have been much larger. So the connection might have moved into commercial and into self-pay because of the way the connection program by definition is designed. If you have access to any other program or you're eligible for any other program, you cannot be eligible for connection.
So then the question becomes, why the relatively standard incline in connection patients from January of 2015 that doesn't appear to be going down?
It's not, and I would say that over the last year and a half, we have done a much better job with eligibility. Michelle Haynes and her group has gone out and done education at many different organizations and done a lot of outreach to try to find different pockets of people within Tarrant County that could utilize the connection program that we were not reaching before. So, you know, since the drop-off, the people that we've been reaching out to, I feel like better utilize the benefits within the connection program. So as Michelle, I think she's talked to us at least once or twice since I've been here for the last 10 months some of those outreach efforts, she goes to, different religious functions, she goes to community functions, and she has really done some education and outreach
So
to.
none of it then is a reflection of any changes in policy as it relates to our acceptance of patients that would be eligible for other programs?
Correct. We have not made any major changes to eligibility requirements as far as who would be eligible. What we have done over the last year and a half is made the application process easier, more streamlined. We've made the access face-to-face easier for patients. Instead of a 4 or 5 page application process, we've made it 1 page. We've made the waiting period shorter. We've become more patient-friendly, if anything.
So Sharon, then, is it fair to say that it's not practically possible for a patient that eligible for ACA chose to go out there and become an ACA patient that now chooses not to, either by virtue of not paying the premiums or whatever decision, they cannot come back to JPS and become a connection patient? Is that true?
That is true. If
Okay.
you have the ability to qualify for any other program,
Okay.
whether it be Medicare, Medicaid, or the ACA, by definition, you would not qualify under a certain percentage of the federal poverty guideline, then you would not be eligible for the connection program.
And my point, and that's what I assumed, my point is they've really done a tremendous job. Getting people
And not only
back
do
in
we
the
try
program.
to sign you up for a connection, but once we realize that based on your income level, you don't qualify for connection, we do get you signed up for whatever program you would be eligible for. So whether we can get you Medicaid if you're a pregnant mom, or have children that would qualify for Medicaid, or whether we try to get you signed up through an ACA program that JPS now participates with, or does not participate with. It is not our job to lead you one way or the other. But we educate you on what program you would be eligible for to try to make sure that you have commercial type coverage.
Well, it's a tremendous job, I'll tell you, and it's something we all need to be really proud of, and it's something to be touting, because it's just a true statement of what this district does to support the mission that we've all adopted, and I just, they need kudos. I think they're doing a fantastic job.
Thank you.
Yeah, because that drove his staff really.
Yeah.
Well, Robert served them pancakes last week, so
we'll
they
buy some more
are really
pancake mix,
excited.
yeah.
That means we may have more ED visits.
That's right.
DT.
Have we tracking to see the exposure that we have since the exchange come into play for those that did not make their premium payment, and we carry out that exposure?
Your question was, do we track?
Do we have enough data to track that yet?
I don't understand the question. Are we track?
That came from JPS connection to the exchange. They did not make payment, but they still continue to use the service, and the insurance will be tracked that. The lack of payment for the premium. So
I'm not sure I can track. I don't have the ability to track who does not make a premium payment to their ACA plan.
But they came in with insurance, but the insurance, we tracked it
Right, yeah.
from us for that payment that they made because they didn't make premium.
So they come in, they look like they have insurance, we give them
Yes.
service, and we find out later on that didn't make their payment, they don't have the insurance, and the government.
Because of the lapse in the insurance.
So-
We're unaware of it. It hits.
I would have a denial code from all insurance plans, but I don't get a denial code for lack of payment. I would just have no longer covered.
But that's the one, we should be tracking that.
We would, but I would not know why the patient would no longer have coverage.
This is true before ACA too, right? I mean, if
Correct.
somebody has, they come in, Blue Cross Blue Shield, they look like they have insurance. We give them care, and then later on, oh no, that insurance had lapsed. So you don't know the difference between non-ACA.
And you know, from an insurance plan, Blue Cross, from, you know, they may, I don't have necessarily a Blue Cross, and you and I are speaking at a very different level than a lot of people in the room may be speaking right now. When I register a patient, I may not be registering, there's not necessarily a Blue Cross, Blue Shield, ACA plan,
Right.
A and B. They may be accessing the Blue Cross commercial plan. I don't know that person has signed up for an ACA product under Blue Cross necessarily.
Would the
Only the plan knows
verification-
that.
insurance
You
verification?
don't know
They
the
are
difference.
not necessarily, that card may not identify them as an ACA participant. So there are some plans that do, but I may not know that that is an ACA product through that plan. But we can talk about that.
But aren't most plans, I mean, don't we all have, we're all participating in ACA, right? We either have a plan that's conforming or is not conforming, and everybody's
I
plan
think
is
what we're talking about, though, is the specific exchange products that have
Right.
resulted for individuals to meet an ACA requirement. So, yes, but we are all under the ACA penalty if we don't have commercial coverage, correct?
I mean, I've changed, I have, every year, for the last 2 years, I have changed my insurance policies based on federal law, because the law made my plan unmarketable to enough people, and they discontinued it. And so, but nowhere does my insurance say I'm an ACA participant in any way, but I've changed my system. And so you don't have any way of knowing or tracking who's changed what or what behavior has been changed in many ways.
DT, back to your question of liability, just make sure I understand. You're saying someone comes in, we think they're under the ACA, and we think they're covered. But because of the ACA's administration, they're past due on they didn't make their premium payments. And then when we
Well, there's
submit.
no way you can tell from the patient
Right.
if they have a Blue Cross that is part of that exchange or not.
That's correct.
But there's a way you can track it because the provider have to sign a contract. In the state, it's pay a lot less.
Correct.
So you can back it in. You can reverse it back, do that. Because
The exposure difference.
they won't pay the provider unless you sign a contract with them.
Gotcha.
What would be the benefit to us to track that?
Excuse me.
Some of that money you'll never see.
First of all, you better reserve for your bad debt, an account balance for. If we ever need to have a discussion on how we take care of these people, we can grab those numbers and say, we are providing charity care, but whatever, you change that to a commercial, but they actually a charity case, because they couldn't afford the insurance payment.
Yeah, we want
That was available at one time or another. It's kind of a part of our mission also as well, when times come, if you start tracking it. But it's still not, right now, it's just a small immaterial number. But, you know, it could mess up accrue for bad debt allowance.
I think a policy decision maker should know how many potential bad debts he's got. That just seems part of oversight, fiduciary oversight.
Loading process, they should know.
They don't care
And the
about that.
provider signed the contract with, or the hospital, when we sign the contract with Blue Cross on that plan, they'll tell us.
I will say that if it's an elective procedure, they do a real good job of working with the client to call them before they come in to say, your insurance does not cover this, or it's not covered with our facility. So that's one of the clues on the schedule stuff that I know they do, because I know someone that was scheduled for a procedure here, and they called them and said, your insurance will not pay us for you to come here. But they did work with them where they could go. You know, this is where it's covered. So I think on tracking, some of that is at the front end. On the elective stuff, they don't usually get that service, that they refer them to where they can get it.
What I'm getting to is, it's not the coverage issue, it's the access issue with those cards. And we need to know so that we can fulfill part of our mission at some point in the future. Because everybody think that it was a coverage issue. You can have a card, you can't get it any other place. We accept it.
Okay. Yeah.
Let's move along.
Okay.
Great discussion.
So I've wrapped up on the medical center, so I think Maria's going to cover PG
Okay.
performance. And I'm going to take your lead and sit at the chair. Thank you, Sharon.
You've set a new paradigm, Sharon.
Yes, thank you. Good morning.
Good morning.
Get my bearings straight here. Very good. So to start off, PG had another excellent month. So, you know, I'm always excited to stand before all of you and share that we're doing great on our encounter budget. For the month of March, we had a favorable variance compared to budget of 1,628 encounters. And on a year-to-date basis, it's 2,077 favorable compared to budget. So very excited about that. Our encounters per day were 954 versus a budget of 901. And as you can see, our departments are doing quite well. The only one that is struggling a bit is pediatrics, but the other departments are doing quite well in meeting and exceeding their encounters, both on a monthly basis and year-to-date basis. Our net patient service revenue per encounter continues to be down. We are not meeting our budget. That does have to do with some payer mix. And then, of course, our net operating expense per encounter, we continue to beat our budget. We continue to monitor our expenses tightly for PG, so very pleased with that metric there. Our days cash on hand is at 263, so we continue to do well there. And our net AR days are at 19. So we've been averaging anywhere from 18 to 20. And of course, our revenue cycle department continues to do an outstanding job. We too do not have much of a change in the payer mix. That stays relatively the same. And going through the income statement, just wanted to point out.
Oh, shoot, excuse me, Mr.
You
Wayne.
guys don't track managed Medicare, managed Medicaid?
I'm sorry?
You don't track managed Medicare, Medicaid at the hospital?
No, we do track that as well. And you know what? I'm going to have to verify. And I'm sorry, I didn't bring all my information with me, where that managed is going, if it's in the commercial part or if it's in the Medicaid. But we do track that. So I'll send a note on that. And then getting to the income statement, there is something I would like to point out. As you can see, we had a fantastic month. We had a loss of $16,000 compared to a budget of $1.7 million. Reason being is we do have a timing difference on our income statement. We had budgeted for the malpractice tail to be paid this month at $1.5 million. And it looks like we're not going to be, that's a timing difference. It will not be paid until probably June, July timeframe. And the estimated number, we're working now with our malpractice insurance individual, and it looks like that number is going to probably come in closer to $1 million. But
But we are, again, still working on finalizing that number. So again, this is a timing difference. We will see that expense hit.
Next month?
Either, well, probably, not next month, I would say probably June,
Okay.
July
Okay.
timeframe. And so again, as you can see, even on a year-to-date basis, a $704,000 loss compared to a budget of 2.645. Even if you remove that 1.5 million from the budget, we're still beating our budget, and PG continues to do a fantastic job. Any questions? Well, thank you very much.
Thank you, Maria. All right, we're going to move to item B. Dr. Fowler, sorry we're slowing you up today. She has another engagement, so she needs to leave.
Morning.
Good morning. We did not need to take to accept it.
The item I have before you is a consideration for approval of a revenue grant to support psychiatry residency training at JPS, and the funding is from the Texas Higher Education Coordinating Board. The funding is in the amount of $225,000, and the funding expenditures will start from July 2016 to June 2018. It supports the salary and benefits of the residents.
Any questions for Dr. Fowler? This is revenue.
Clarification, what is revenue grant? I'm not familiar with that.
So it's revenue, it's not cost to the district, and so the grant is to support, just to support slots that we have available that otherwise we wouldn't be able to pay for their salaries. And so this supports to have those residents in those positions. They have 2 FTEs that we can't fill because we don't have money, but now we have money to cover them.
So Dr. Fowler, the 225 that we received is based on what we requested or based on what they determined?
So they determine how much per resident. So we have, again, 2 positions, and we tell them how much that cost is. So that includes the resident's salary plus that 20% F&B, 26%.
Good job.
We decided we wanted this position, and we went to them and said, we'd like to do this, will you give us money, or how did that, I don't understand how that happens.
So this year, they had a new grant for unfilled positions. In the past, we had not applied because they didn't cover the whole salary. So I'm actually on the GME funding committee. So we argued that the state would pay the whole salary, and they approved it. And in addition to that.
I'm sorry, who's they?
The state, the legislature.
Okay, the state legislature has a hearing, and they have a committee, and they pass a bill that says we get money for
Yes.
this purpose, okay.
And
Specific to this purpose. It's
Specifically
specific to
for this
Yeah, it's part of the annual, biannual budget for the
Yes.
state, right?
State funded, yeah.
Graduate medical education.
So we applied for state funding.
Okay, thank you.
Okay, any other questions for Dr. Fowler? Yes, sir. We have a
Second.
motion and a second. Any further discussion? All in favor, please say aye.
Aye.
Opposed? Motion passes. And
Thank you for getting
we're
that.
gonna, I'm gonna take one thing out of order, so we can benefit from Dr. Fowler's expertise. Item H, we're gonna move up. I'd like to consider that now. And Dr. Rosini. Yes, ma'am. Who made you boss? No, I know. No, I forgot, sorry.
Who made you boss?
So, one thing that we forgot to do, somebody forgot to do on a prior action, on item A is the financials. We have to accept the, we have a motion for from Mr. Powell to accept the financials.
Second.
And a second by Mr. Bose. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes.
Maybe she should be the boss.
Thank you. Okay, item H, please.
Great, thank you. I'm going to speak to the medical education agreement between Tarrant County Hospital District and Acclaim. I'd like to point out before I get started, midway through the executive summary, under the title of Strategic Plan Alignment, in the second paragraph, there's an error I'd like to point out, and it's the specialties that are listed. We don't have an internal medicine program. We have a department, but we don't have a residency in internal medicine, so that's a misprint. I just wanted to point that out before I speak to this. This agreement, does everyone find that? Just, okay. Thank you. I apologize for the mistake. This agreement is a consolidation of the medical education agreements that existed separately with JPS, PG, and the UNT Health Science Center. This is a consolidated agreement. It makes a claim the provider for the educational services that exist. It is budget neutral. There are some new performance compensation programs that will be developed but are not developed today, so I can't speak in any detail about those. The formula that exists around GME, there is no change in that formula. And this is a 5-year agreement that can be amended at any time during the agreement. Again, it's cost neutral, and I'll open to any questions. And there were some questions I think submitted this morning, and you know, we had a discussion last night about this agreement, and we're going to update the document, and I think we're going to send out a formal response to those questions, because I thought they were wonderful. So, any questions on this agreement?
So this is an agreement we're making with a claim to teach people to be medical professionals. Am I getting that right?
It's the same book of business, and instead of having an agreement between the hospital district and JPS PG and UNT Health Science Centers, all that's going to go through a claim today, going forward. So it's the same business.
I continue to have the same question as to why county does this at all, or to what extent it should be doing it. That's another philosophical question we get another time.
So, yeah. I love that question, but I don't want to go down that. I would love to have that conversation with you,
this is, you know,
but I don't want to go there now.
It's amorphous. You know, we're paying a bunch of money to educate a bunch of people so they can go make high-paying jobs and everybody pays taxes to give them the education. I'm not sure that happens in very many professions.
Any further questions for Lisa?
I just have a statement I want
Yes,
to
ma'am.
make, that in this agreement, and part of that is we need to make some changes so that there's a conflict in some of the information on what Bill is bringing forward in this contract. And so just so long as that is pointed out and that we make those changes, you know, on your section on billing and compensation.
Okay.
That's
Thank
one
you.
of those areas. And I sent the question, sorry I couldn't get them to you earlier.
No, thank you for sending them
Okay.
forward. We're going to respond to those.
Okay.
Thank you so much.
Okay, and I think on that, maybe I can get with Scott or you later, but before that document is actually approved, I think we need to have those corrected.
I agree.
We agree, Dorothy, and certainly before the board approves it, we need to resolve those discrepancies.
Where did it talk about it in 5 years? Oh, there it is. Was the previous contract a 5-year contract?
I don't know.
I think oftentimes they were generally 5 years. Sometimes they were a little shorter. If they were ever shorter, they were 3 years. It generally corresponded with the term of if you had a contract with them for professional services, it would correspond. So if you had a 5-year PSA, you'd have a 5-year MEA.
That's correct. Historically, the PSAs and the GME have all been synchronized.
They were within those physician contracts, so it's always a part of that. So this is different. They've separated it out to have an alignment of, well, I guess a list of things that a claim will be held accountable to make sure that those providers are doing. That's kind of how I see that. And it's spelled out pretty, I think, well, saying the responsibilities of the program directors. And I have some questions about chairs because they look like they are just floating around and is it responsible for that? But that's a difference in philosophy. So.
Agreed.
So the question on the table is it this to be approved with understanding there's going to be clarification prior to any, these
Correct.
questions being answered prior to any approval finally, obviously by the board.
Absolutely.
So moved.
We have a motion by Mr. Petty with those clarifications. We have a second. Second by Dr. Weber. Any further discussion? All in favor, please say aye.
Aye.
Opposed? Thank you. We passed.
Dr. Rosani, I know you're a good doctor, but you're also a pretty good politician. What you stayed away from.
I'm gonna leave the table.
You handled that very well.
Does
I thought he was good with that one.
With the questions answered, it'll go to the board.
Yes, sir.
Can we, I don't know what questions were asked and what changes might be.
I'll forward to you. It was just general questions, and I can forward my questions to you.
Yeah, I mean, could you
Okay.
do that so we,
Let's get it.
Yeah.
Just I want to make things, we have to get it right.
Actually, I think Trent's motion actually dealt with that those questions would be, addressed when it comes to the board for.
right, I just like.
But he wanted to see them prior to.
Right, that's what I'm saying, right.
Discuss, what were the questions?
Oh, the compensation question?
Right.
Dorothy, you said that.
For the,
I
Yeah,
can't,
just, you don't need to do it now.
No,
Oh,
we'll,
okay.
Scott will do it. Scott will help
Scott will-
distribute that, yeah.
because I forward my questions, kind of like we talked about, to Steve and to Ralph and said, here's just some general questions so they would
Right.
know. And I don't usually send it to all the board because that's one of the deals that Neil kind of said we didn't need to do. But now I'll forward my questions over to the rest of you. It doesn't, I think they're legitimate
I
questions.
know that Neil probably doesn't like it, but I like to see what the questions everybody has. I just do. I do.
All right. I will hit that
I
button
think
as
so.
soon as I get home.
I think,
I'd agree.
yes.
oh, yeah, Scott. We're gonna post them on the portal. So, I mean, they certainly should be accessible to everyone.
Yeah.
Send them out, just a bunch of
Yeah.
answers back.
And they will be.
When Dorothy sent the questions to Steve and I, we looked at them and sent them back to her and said, wrong people.
Put them on the portal and let everybody get this.
Number on, wrong number.
Wrong number. And we'll make sure that item is not on the consent agenda either, accident, so we
All right,
we'll
thank
make
you.
sure it's an item of discussion.
I like the way you're thinking.
So I'm going to table item C. We have some more numbers that we need to get clarification on, so I'm going to table that. We're going to move to item D. Mr. Whitman,
Thank you, sir. Good morning.
good morning.
We are anticipating standing a claim up May 1st. We had an executive committee meeting this week. And what you see in front of you on this particular agenda item is a professional medical service agreement between the district and a claim. We need providers to provide services within a claim. This is a little bit different than the contracts that we historically have had with UNT and PG, but they conform to the professional medical service agreements that we've structured over the last 3 to 4 years. So in this agreement, there will be a declining compensation for provider services from 105% of Medicare to 100% of Medicare to 95% of Medicare. There will be a declining administrative compensation from 100% of current base to 95% and 90%, with incentives to offset some of that decline over the next 3 years. So in essence, this is for PG and for UNT providers to provide services to our connection population and to receive payment in return for doing so. Be happy to answer any questions anybody might have.
Any questions for Bill?
Bill, one question I have that I did send to you, and by the way, I'll send you all my questions I asked on this one too, is there is a lot of these things that we list that they will do. And who will be the person that's going to be monitoring this? How will you?
The president of a claim.
Yeah.
Okay.
What did you say, Bill?
The president of a claim.
And that report will come back to the board?
To the
quarterly?
executive committee and then to the board.
Okay, all right.
In regard to
Because
performance.
there were a lot of things in the contract that
Correct.
has the stuff. And I thought it was a decent, laid out very well of the things. Would ask that y'all go back and relook at the chair's responsibility, because I think if you're over a department, that somewhere in all of that, they should be accountable for all the stuff that's happening. They have they have a teaching program. It's spelled out very well about the medical directors and the regional directors will counsel and do things, but it's missing in that.
Where you're going to see that, Dorothy, is in the key performance indicators that are structured for the chairs, because the chairs have overriding responsibilities for those functions. So the metrics will deal with perhaps teaching, with perhaps clinical metrics that are established. They're responsible, and they're accountable.
I really think they will do that, but in your contract, there is not a statement in there that they will be accountable. That's all I'm saying.
Okay.
That's all I'm saying on that one. Because it kind of stood out when you read it, when you looked at the directors and regional, it was clear that they were going to be responsible. When you read the
And they report to the chair.
right, and the
right.
chair is just sitting there like, okay, y'all take it. So that's all I'm saying on that
Gotcha.
one.
Gotcha. Yes, sir.
Bill, if I may, Dorothy brings up a good point that just advise everybody, because we're not serve on that committee, but at the end of the day, there is a process of which DT serves on the selection committee. We haven't identified the candidate, he or she, we don't serve on that committee, so when that individual is found, right now, Dr. Johnson's acting as the interim president, trying to do everything and along with assistance from staff, but hopefully that individual, he or she will be coming fairly soon to this board and everyone else for approval, to be the president, CEO of the claim. I think DT's probably got more information.
The process has been
The pro-
really good.
Good. Thanks, here too.
On this one, let me point out, I mean, it's, this is behind Medicare rate, even though we have declining based on the performance, quality measure, it's still a really good contract, because there's no co-pay deductible cost collector to the physician group. So it is a good contract.
I think that, the question Dorothy raised, I think is really valid about the chairs. But I think that's when I asked Bill what he said earlier. But I think there's also the check and balances, because all of that comes to the acclaimed exec committee.
Correct.
And for review, then it comes to the board. So that will be
Routine reporting to the board. Right.
Any other questions for Bill? I entertain
Recommend approval.
a motion by Dr. Weber, a second by Mr. Nguyen. Any further discussion? All in favor, please say aye. Aye. Opposed? Motion passes. Thank you, Bill.
Thanks, Bill.
Diana. Item E.
So Sharon started a new trend. Everybody's sitting.
Yeah, it's a new vibe now.
Which one did you pull? C?
Item C. Read back.
Good morning, and I would like to say that we do appreciate being able to sit at the chair. Thank you. Thank you. The first item I have before you today is consideration and approval of professional services agreement between Acclaim and Tarrant Nephrology Associates. And as just a reminder, this has been considered and approved already by the Acclaim Executive Committee. This is a contract that currently exists with PG. We'll be transitioning this to Acclaim. It's neutral, it's already budgeted. There are two parts to the service. The first, as you can see, is lecturing, teaching, and consultative services. The second is the 24/7 coverage, inpatient and outpatient. So for this year, budget neutral, will see a little bit of an increase as we start the new fiscal year, because Nephrology Associates is willing to provide more coverage for us as that patient population continues to grow. And they have, by the way, a very high patient satisfaction rate for the services that they perform. This is a 3-year agreement currently. There will be, like all of our contracts, KPIs and KAPIs developed during the first 90 days. Dr. Rosinia is already on that, and so certainly we'll bring those back to the Acclaim Executive Committee as those are developed, but those will be developed in the first 90 days.
Great. Thank you, Diana. Any questions for Diana?
Motion approved.
Motion by Mr. Petty,
Second.
second by Dr. Weber. All in favor, please say aye. Aye. Opposed? Motion passes. Item F, please.
Okay. The next approval I have before you is the Administrative Services Agreement between Acclaim and the JPS Health Network. Again, this has been considered and approved already by the Acclaim Executive Committee. These dollars are budgeted. These are for the services that the corporation, the Tarrant County Hospital District, provides to Acclaim so that we do not have to duplicate those services within Acclaim. The list is on here for you, the details. As you can see, the percent of FTE from each of these areas that support our ability to function as a physician group.
Any questions for Diana? Entertain a motion for a motion by Dr. Wade.
Second.
Second by Mr. Bose. All in favor, please say aye.
Aye.
Opposed? Motion passes.
Thank you.
Thank you. Scott Rule. Want to do item D?
Good morning.
Good morning.
This committee will certainly remember that at its January 28th meeting, it approved a lease between University of North Texas Health Science Center and the district. That lease was subsequently approved at the February 11th board meeting. This particular action item just apportions that sublease for use of the district and a claim. So it's just a sublease of a lease that's already been approved. As we stated at the time that we approved the underlying lease, this really provides a centralized location for community health administration and a claim administration.
We pass it through at the same rate.
Yes, everything's passed through at the same rate, based on square footage. Claims apportionment at the current time is about 40%. Yeah, just a little.
about 40%.
Any other questions for Scott?
Move approval.
Motion by Mr. Bose, second by Reverend Emerson. All in favor, please say aye. All in favor, please say aye. Aye. Opposed? Motion passes. Thank you, Scott. Skip down to item I. Sharon the boss Clark.
I like that.
The boss.
And I'm gonna kind of kick it off because in the absence of Neil, and he apologizes, he's serving as a pallbearer today, so for him not to be here, he regrets that. But this is a resolution to authorize the general counsel, the CEO, and the CFO of JPS to carry out the necessary actions for winding up in the dissolution of JPS-PG. This resolution is necessary per the bylaws and the articles of incorporation of JPS-PG, and the action that's being taken today is by JPS or the district as the sole member of JPS-PG. This is taken today is just recommending to the Board of Managers that we adopt a resolution authorizing the necessary actions to carry out the winding up the dissolution. So you'll see in your the insert that you have for this particular item, there are several bullet points that describe exactly, point by point, what the resolution is accomplishing. If you have any financial specific questions, I think that's what Sharon is up there for.
Alan, just want to reference that as part of this, it's my understanding, because of the claim, that all the notices and everything that was required, the timelines to notify on the May 1st or whatever, all those are in the process or have been sent out. Is that correct?
I believe so.
Thank you.
Okay.
That's correct. And this is part of the normal process. I think Sharon would confirm that.
It was looked at by claim legal counsel and by our general counsel. Yes.
Yes.
Yeah. Okay.
So, from my experience, this is just part of the normal wind down of a corporation. And from my experience, it will likely take 12 to 18 months to collect out the existing accounts receivable in PG. So it will be a lengthy process. There'll be a lot of activity in the next 6 to 8 months. And then as it goes out, as time progresses, there'll be less and less activity. And it will slow down as time progresses.
And you'll keep us apprised as we go through it.
I will,
activities.
yes. So, again, there's a lot of liabilities, a lot of assets at the moment. And then as business slows down, those liabilities will be first off the balance sheet. Accounts receivable will continue to come in pretty strongly for the next 6 to 8 months, but we will continue to collect on those. I would say, for the next 12 months. And then for the next 18 months, they'll trickle in, and we'll just kind of see where we're at and what the value of those are at that point in time.
Okay.
So it's a
Yes, ma'am.
lengthy process.
I guess I'm trying to clarify, is that payments you're talking about, the different things happening?
Cash
Will the
in.
Cash coming in?
Yes.
And will that go to JPS? Is that gonna be,
PG is a wholly owned subsidiary, just like a claim is, of the hospital district. So those are assets of the district. So correct. That's what will happen
Bless you.
to the assets. Now, if you read the winding up dissolution, this gives me the ability not only to take assets out, but put assets in. You know, if there's liabilities that turn up, it is, my responsibility. If there's a liability in the future of PG that we need to take care of, I can take assets from the district and transfer those to PG so that I can pay any liability that might arise. So,
okay, now I guess.
it's part of the wind
yeah.
down. They're
That will
not
be kept
foreseen.
separate. Okay, but so the dollars coming in will be kept separate, so we'll know what's.
For a period of time, but that's the definition of winding down a corporation.
I understand that,
They'll
but-
ultimately enter into an asset transfer agreement and bill of sale.
All right.
They are.
So that will happen later.
I want to see what you're gonna get.
Well, I do have a question.
But, the assets will be transferred over to the hospital district that remain in PG.
Okay.
I think last year we were talking about the $19, $20 million sitting in there.
Yeah.
What happened to it?
It is still there. And,
Believe me, I ask about that often.
yes,
That's part of all this.
Is it being
Yeah.
applied,
Uh-huh.
the same investment type thing that we are doing at the JPS level?
so let me remind you, as a hospital district, the investments that you're allowed to enter into is not what you would enter into from a normal commercial investment. The PG investments have been relatively conservative, even compared to those at the PG. So most of theirs is left in cash. And, but those assets that are remaining on the balance sheet will be transferred over to the hospital district, and they will become, once again, the assets of the hospital district upon dissolution of PG
Subject to our investment policy.
into our investments.
Okay, that was his question.
Dr. Weber.
My question is a simple one, in winding down the organization, JP, the assets that you're talking about are the assets, a lot of that will be services provided by the physicians, correct?
No, the two main assets that are, and by assets, we're talking about what's on the balance sheet. The two main assets that PG has at the moment are cash and the accounts receivable, which will eventually turn into cash. So, and on the other side of the balance sheet, they have payables from a liability standpoint. A large payable that they have, Maria just spoke about, which is some of the tail coverage that still exists for the physicians as they exit their contracts with PG. So as all of that starts to move, we will need to, that's part of the closure of that company. So we will transfer the cash that has remained on that balance sheet to the district. And we will also draw down and collect out all of the accounts receivable that remains on PG's books for the next year, year and a half. And we'll take care of all the liabilities that remain with PG. There may be some that are not yet recorded, but over the next year, year and a half, we will make sure that they are. And then at some point in time, we will be coming back and I'll be recommending that we actually close PG as an entity after we're sure that all of the business activity has ceased.
Okay.
But that will likely be a year and a half to 2 years from now.
Do we need to put seed money, in essence, into the newer claim for
Um,
operating purposes?
We will, and we're looking into that right now. That would probably likely just be an intercompany. It may be able to cash flow, and we're looking into that because it has a professional services agreement right now. And that seed money may or may not have to occur. So we're doing some analysis as we speak, actually.
So credentialing will be able to move over all the provider ID when Medicare, Medicaid will be over?
Credentialing is not, no, you don't move over the Medicaid ID. We're having to reapply and get brand new.
Yeah.
So all of that is it's a new, a claim is a brand new entity. That's a separate conversation. But the closure of PG allows us to open up a claim as a new entity. So we're not moving PG to a claim. We have to close a claim and we have to open up a brand new tax ID number to start a claim. So this resolution that you're voting on right now allows me over the next 2 years to start that wind down process. And will immediately start the wind down process for PG.
Should we or will we anticipate a lag in billing because of that switch? If what was involved with this? Any anticipated glitch that we may cause to our billing payment receiving type thing?
Anticipation of a billing lag, just based on the definition of billing alone, there's going to be probably a 30 to 60 day time frame where you drop a bill and it comes in from any new entity. But we're doing our best to put controls in place so there's as few glitches, as you put it, to timing. But again, the hospital district would be able to do any short-term funding from that standpoint to make sure that that entity would be able to, if you're talking about from a claim standpoint, we would be able to make sure that a claim could cash flow on a short-term basis.
Sharon, in reference to DT's question, even though there's a lag, there's not a loss of potential revenue.
Correct, it would just be
As you-
timing.
So, yeah, I totally agree with you too.
Right.
And I think, again, one of the timing issues, although, like I say, there's a lot to happen here, this is coming about the same time as, this board's fixed to enter into the budgeting process as we go forward as the district. So this gives Sharon an opportunity to kind of start looking at both and not Sharon, when she comes back to this board, she and her staff, they come back and make those presentations, and we should be able to look at both of them. And when
You
they
had
move over.
I would assume you had a very similar timing lag when you started up. PG is an entity.
There was.
So,
Is the lag on PG over? It's just a timing issue, right? But then you also double up the payroll
Mhm.
because of the UNT side of it.
Yeah, those are performance,
That's my
exactly
point.
right.
I
That's
wanna know
what
if
Sharon
we
needs to
need
know.
to allocate.
Well,
We
UNT
prepare
is
for it.
not, again, this doesn't really have this is aside from the resolution, but the UNT is not a double up of payroll. UNT is just a transfer of the payment, right? Because UNT is not a payroll. We are just transferring the purchase service agreement from the hospital district to a claim. So instead of paying the purchase service from the hospital district now, we will be paying that from a claim. So there's no timing or doubling up from the UNT purchase service agreement. It's just, instead of paying it out of one of our entities, we'll be paying it out of the other of the entity. So it's not that's just a purchase service.
Okay, any further comments, council? All right, we've heard the explanation and questions. I'll entertain a motion for approval.
So moved.
Motion by Dr. Weber, second by Mr. Nguyen.
Thank
Further
you.
discussion? All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, Sharon.
Thank you, boss.
Thank you, boss. Great show.
They get a new name tag, too.
That's right.
The boss.
Put it on her door,
The
her
boss.
office.
Yep.
The boss.
Okay, I would like to state this is not an agreement with the claim. This is actually an agreement between the Tarrant County Hospital District and our area ambulance authority, MedStar. Again, this is an agreement, this is just, we're asking for our new agreement. There's no change in price this year. We are anticipating potentially a 10% increase based on transport. These are for transport services for non-emergent patients that we're moving from our hospital to other facilities or potentially between our facilities as we need to for patients. Fiscal year 2014 and 2015 are there for you. We only pay if we use the service, but that's about what we would anticipate going forward.
Per call, it's a per call cost.
You were correct.
Roughly how many calls do they make for us?
It's actually in the back, and it's quite a few, right, calls. So the emergent and non-emergent, and I don't know the total, but it's several thousand, I think. So.
Several thousand.
Mhm.
Okay, any questions for Diana?
We move a lot of patients.
Yes, we do.
Devin, it looked like you picked up a new area that the number
We
really went up.
did. We did pick up Sansom Park as a new area. Mhm.
Entertain a motion.
So moved.
Motion by Reverend Emerson, the second by Dr. Weber. All in favor, please say aye. Aye. Opposed? Motion passes. Thank you, Diana. Jamie, item K.
They made you sit in the other room.
Good morning.
Good morning. I'm Jamie Polai, Vice President of Support Services. I am presenting a second amendment to the contract with Hospital Housekeeping Systems. Adjustments to the base contract reflect cleaning services to TSP North and to May Street, and improved staffing to the second shift housekeeping team in the patient tower and the patient care pavilion. We are also providing additional staffing to the expanded admissions holding unit. The dollars for TSP North and May Street are budgeted. What's not budgeted are the dollars to meet the cleaning needs of the admissions holding unit. We are, however, able to offset that expense with the incentive pay that Hospital Housekeeping Services has paid us for, unfortunately not meeting the performance metric that was set in our base contract. If there are no questions, I'm requesting that this committee approve the Second Amendment.
Any questions for Jamie?
I'm always easy to approve a second amendment.
Is
that a motion?
You're the man.
Was that a motion?
Yes.
Second. Second.
So we have a motion by Mr. Norred, a second by Mr. Powell. Yes, sir. Question.
If they didn't comply with some areas, we worked that out before we approved this amendment, because we're saying now we're giving them more work. We're approving them to do more, but they didn't reach the standards we asked them to reach in a certain area before. So how do we address it?
Correct. Very good question. So there were 3 metrics that we set in place in the base contract, and if they did not meet those metrics will continue and will include the expanded areas.
Right, but we have some in to make sure that they reach those metrics this time and it's supposed to. Yeah.
Correct, yes. And unfortunately, if they don't meet the metrics, then they are paying us an incentive, a portion of the contract management fee.
And what of those 3 areas that they did not meet?
So they did not meet 2 of the 3 metrics. The 3 metrics we have in place, one is for our HCAHPS survey as it relates to the cleanliness question. The other one is for their employee engagement satisfaction survey, and then the third is for our district leadership satisfaction survey. They did not meet HCAHPS, nor did they meet the district leadership satisfaction survey score. But they've made significant improvements. We set some high targets when we wrote this contract with them a couple of years ago. Since then, they've made improvements, and they are headed in the right direction. Just unfortunately, they didn't meet the target that we put in place.
Okay, we have a motion and a second.
I do have a
Yes, sir.
question.
Yes, sir.
Who's responsible for the office buildings where the physicians are? Are they the same group?
Which building, are you referring to the JPOC buildings?
Yeah.
Yes, it's by Hospital Housekeeping Systems.
As a comment, one of the first things, we added 3 community members to the quality committee. One of the first things that one of the ladies said about services provided was that the bathrooms were awful. And that she just didn't want to go in there. That to me said a lot. That's why I asked the question. And then hearing that they did not meet their performance criteria, I mean, it's good.
Okay, so I will follow up.
You see, that's the type of input that we would have never, ever heard.
I would say Dorothy raised that issue some months back.
Okay.
It only happens if I have to went to the facility, used the facility with my sister, and that was one of my concerns. It wasn't in the old part of the hospital, it was over in the new pavilion that I had it, so, yeah, so. I'm glad that, but I am glad that you do have a contract where there is a penalty when you don't meet it. There is not that in a lot of those contracts, so I think this is a good way to say, okay, you come back, and then I would say that as they are improving, because we as an institution didn't meet some of ours, and we are improving, so hopefully they will meet all those standards.
I agree.
If they don't, there's going to be another action. I mean, that's the other side.
Just a quick
That's
question, Jim. Do we have in the service level agreement or whatever that is, how many times a day they need to clean? Or do we restrict them to certain times of the day to clean? Because I don't want to blame them for something that we trying to cut costs ourselves and only allow them 1 or 2 times. And we have high traffic before I vote, because I don't want to be unfair to people.
Good question. The frequency of cleaning is mutually agreed upon. So we do have a cleaning schedule in place that they had coordinated with us, and vice versa.
Is it a failure on our side not to increase the frequency on high traffic area, or is it the decision is made by them based on their recommendation to us?
It's both. So in areas of opportunity that we need to improve on, it needs to be identified by both. So by us and them, if we need to increase cleaning in one area and decrease it somewhere else, we just need to connect and make that happen.
But in that situation that we know of, is it because of us or because of them not providing it before I vote?
Most likely them. It would have been a cleaning, if it was a lack of cleaning on their part, then we're holding them responsible to that schedule, the cleaning schedule.
All right, motion and a second. Any further questions? All in favor, please say aye.
Aye.
Opposed? One no. Motion passes. Thank you very much,
Thank you.
Jamie. Go get them.
Thank you.
Mr. Mendenhall.
Thanks, Jim.
Good morning. In front of you, you have a renewal contract with AT&T. This is to cover the circuits that we have going from our JPS data center that we have at the main hospital all the way to the Richardson data center that about 45 miles away. These are for those circuits. It's a 3-year agreement, and you can see the cost right in front of you.
Any questions for David on this?
Move approval.
A motion by Mr. Bose, a second by Reverend Emerson. Any questions? All in favor, please say aye. Aye. Opposed? Motion passes. Thank you, David.
Thanks.
Melinda.
Winner.
That was the shortest one.
Good morning.
Good morning.
The next item on your agenda is regarding Kronos. You may remember Kronos is our time and attendance system. All of our employees, we have clocks all over the premises, and our employees clock in and clock out on those. It's also where they record their time off, their sick time. We've had a contract for over 7 years with this organization. We renew it on an annual basis. This is a renewal of that contract.
Second.
Motion by Ms. Burt Emerson, a second by Mr. Bose. Any questions for Melinda? All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you.
I may not look like Kathleen. I'm honored to be able to represent her, but she is out ill today and asked if I would. So the next two items are hers. They are very related, though, so I wanted to make sure you know about that. It refers to the glucose meters. A lot of us know that term, glucometer. That maybe is a more familiar term to us. It is a medical device that measures the amount of glucose in the blood, checking for diabetes. We are going with a new model of the glucometer, one that is much more sensitive and better used for seriously ill critical patients. The FDA has said that this is a much better type of medical device if we really want to look at somebody who's in a serious situation. So it's a wonderful thing, actually. It's a 7-year contract. Any questions about this? It does include the glucometers themselves as well as the test strips and the supplies associated with it.
Okay,
I
you've
move
heard.
approval of
We have a motion by Mr. Bose, second by Reverend Emerson. Any questions for Melinda? All in favor, please say aye.
Aye.
Opposed? Motion passes. Item O.
If you move to item O, this is a piece of what we refer to as middleware. It's actually the interface of the point-of-care glucose meter itself to the soft lab system, which then transfers that result to the Epic electronic health record. So we need to get that data where all our physicians and nurses can see it. So it is simply an interface. Notice that there's no cost associated with it because it was included in the first-year contract of the previous agreement we just discussed. We'll come back in the following years for the interface associated with the remaining years.
Motion by Mr. Petty, a second by Mr. Powell. Any further questions? All in favor, please say aye.
Aye.
Opposed? Motion passes. We'll
Thank
tell
you so much.
Kathleen you did a great job.
Yeah, I'll tell Ken.
Oh, Melinda, I'm sorry.
Before you go, I'm not sure if this board and you guys know, but Melinda is nominated to be one of the most powerful women in healthcare IT.
Yes.
All right, congratulations.
Only because I am working with a wonderful team.
Oh, thank you for letting us know that, DT.
Great job.
Her the boss,
I don't know.
or
She's,
her the boss?
wow, good question. Okay, we have no report from legal counsel, right? We have nothing in closed. Any other items before the committee? We are adjourned.
Okay.
Oh, yeah.